Good afternoon. Thank you for joining us. Today we're going to give you a series of updates on COVID-19 and then hopefully have time for questions. Next slide. Next slide. As you've probably noticed, the official name of the novel coronavirus disease that we've been addressing in the last weeks is now officially coronavirus 2019 or COVID-19. The case definition for COVID-19 in China is changing. Chinese authorities made a change to include clinically diagnosed cases without laboratory confirmation to be counted as cases in Hubei province. This created a large increase in the number of cases on or around February 13th. However, we are hearing that other changes are being made to the case definition. The bottom line is that the case definition is in flux, and numbers going forward may reflect that. Having said that, globally, as of yesterday, the WHO reports 75,204 cases, 74,280 of which are in China. Cases are being reported from approximately 29 countries. There have been 2,006 deaths reported in China and 3 outside of China. News reports have stated that the rate of increase may have slowed in the last few days. From the WHO Situation Report of February 19th, the Chinese Center for Disease Control and Prevention is reporting that the case fatality ratio, or the number of deaths divided by the total number of cases at one point in time, to be about 2.3% in China. This is certainly not definitive yet, and we can expect to see different numbers in the future. This is a screenshot from CDC's website. In the United States, there have been 467 persons under investigation, or PUIs, for COVID-19. This includes, for the most part, individuals who had symptoms and who were scheduled for testing at CDC. Of those, 15 have been positive, 392 have been negative, and 16 are pending. Here's a screenshot of the New York State Department of Health webpage that shows the situation in New York State. There have been a total of 25 PUIs in New York State, 6 in New York City and 19 from the rest of the state, and all have been negative. I will now turn this over to Dr. Dimitri Daskalakis from the New York City Department of Health.
Thank you very much. And I'll continue on to a slide about New York City updates, which is up. So again, as you've heard, we've had 6 folks from New York City tested for COVID-19. 0 cases have been identified in New York City. I also wanted to make sure that folks were aware of some updated information available on our public and provider site. We have new guidance for colleges and universities, FAQs for New York City schools and families, FAQs for businesses and employers. Additionally, going up later today, I think, right? We said going up later today for individuals who are on home isolation or home quarantine, there are doctor's notes available for school and work. So if there are sort of folks returning from China, those will be up later today, along with some FAQs for individuals who are at home doing self-monitoring. The provider site will also include new FAQ for health workers, which I think just went up today. Next slide, please. This is a screen capture of our provider page, and again, this is where you'll be able to find the links to all of that new material that we're talking about. Keep an eye on this one. We have new FAQs and guidance coming out every day, so just realize it's there. Take a note and visit it frequently if you're looking for updates for providers. Next. So then I will talk briefly about some new literature. So as you'd expect, there is a explosion of publications that is occurring around COVID-19. So I'm going to give an aerial view of some of the more interesting. I'm sure I'm missing some things in general, but I think important things to think about. So I'll start with epidemiology. So I'll remind people about the idea of a basic reproduction number, or R0. This number is a measure of expected number of cases directly caused by one case in a population where all individuals are non-immune or susceptible. So in other words, the number of folks who will have forward transmission from a single case of a transmissible agent. In this scenario, we're talking about the virus that causes COVID-19. This number is affected by environmental factors, and it does not only reflect the characteristic of the pathogen, and it's usually generated through mathematical models. So just to wrap your head around an R0, if your R0 is greater than 1, that means that the infection will likely be able to spread well within a population. If it's less than 1, so less than one person is being infected by the index case, the infection won't really spread widely. So in general, the larger the value of an R0, the harder it is to control the epidemic. So currently, studies continue to estimate an R0. One recent one estimates it to be between 2.8 and 3.9, which is around pandemic flu, which is from 1918, which at its maximum R0 was thought to be about 2.8. So potential for transmissibility is there. It's slightly higher than the R0 for SARS. And really the idea is that this is a theoretically controllable disease with moderate to high transmissibility, and that really the key is active, timely and effective control measures to prevent further transmission. So this number will change as more modeling happens and we learn more about the disease, but again, important to sort of have a sense of what transmissibility looks like for this virus. From the clinical perspective, I'll start with some PEDS updates. There have been a few case reports in recent literature describing some adverse outcomes in infants born to mothers positive for the virus that causes COVID-19, for instance, preterm birth. But it's unclear if these are the direct result of viral infection. Additionally, 2 new articles looked for evidence of virus in newborns. In other words, newborns who are born to mothers who are infected with the virus that causes COVID-19. Both of them, 1 of 10 infants, showed that there was no virus in these deliveries, and another study showed 19 infants born to mothers positive for the COVID-19 virus that were all birthed by C-section did not demonstrate any transmission. So good news from the perspective of vertical transmission of COVID-19. There's a recent study that came out around clinical characteristics of patients in tertiary care. This one looked at 137 patients in tertiary care. Their age ranged from 20 to 83 years of age. Mean was 55. Again, confirms that fever, cough are prominent symptoms. About 81% presented with fever, a little bit less than 50 with cough, but they also noted some muscle pain or fatigue, about 32%. There were some other less typical symptoms such as heart palpitations, diarrhea, and headache, but those were very low frequency. Nearly 80% had a normal or decreased white blood cell count, and almost 73% had lymphopenia. Additionally, radiology, which I'll talk about separately, demonstrated lesions in multiple lobes. So usually some sort of ground glass type or multifocal pneumonia. Additionally, in this study, systemic corticosteroid treatment did not show a significant benefit, and also found that the risk of death from COVID-19 was associated with age, underlying chronic diseases, and also the median interval from appearance of initial symptoms to dyspnea. So I guess that is a marker for time to presenting to care as well. Lab findings. Interestingly, one paper showed that the viral load of the virus from patients' respiratory tracts was linked to lung disease severity, and another paper demonstrated the presence of virus in saliva, so consistent detection. And also this study, though we should not be doing cell culture for any diagnostic, in this research study they did cell culture and identified that this was in fact live virus detected in saliva. From the radiology perspective, there were 2 studies that I'm going to report on. One reports CAT scan findings among 51 patients with COVID-19. The main finding was that most, 77%, had ground glass opacities, and usually of those with ground glass opacities, almost 90% had bilateral findings. And also interstitial or interlobular septal thickening and consolidation were also common. A second study also looked at individuals who presented with symptoms but tested negative for the COVID-19 virus on PCR. what they found was that those individuals at their baseline had abnormalities on their chest CT. So they saw the ground glass opacities or consolidation. So really bringing into focus the potential need or the role of CAT scan in looking at individuals presenting with symptoms even before we have a viral diagnosis. In terms of treatment, a couple of things. A study published in the Proceedings of the National Academy of Science showed that the antiviral remdesivir reduced the severity of disease, viral replication, and damage to lungs in individuals who had MERS. So the implication is potentially this drug, which is already being investigated, may have a role in coronavirus that causes COVID-19. Additionally, in terms of transmission and shedding, there have been several articles that describe possible transmission of the COVID-19 virus from asymptomatic people. For an example, there's an article in the New England Journal that shows the results of screening a group of people returning to Germany from Wuhan. In that group, there were 114 asymptomatic people who were tested, and they used throat swabs to detect the virus. They found that that shedding did, sorry, I said that wrong. So among 114 asymptomatic persons who were tested upon arrival in Germany, throat swabs detected this infection in 2 persons. So not a large number, but definitely asymptomatic carriage was potentially demonstrated there. That virus was, again, live because they cultured it. Footnote, again, do not culture for this virus in your lab, not allowed. You should only be using the currently CDC-based assay that we would help you with in New York City, and the state would help you in other parts of the city or the state. And so really, though this demonstrates, again, the possibility of asymptomatic spread, it's important to remember that really that's not what's driving this outbreak, that the majority of this is being driven by symptomatic people. So good to know that that asymptomatic folks could harbor virus, but it's not the way that this is moving forward. So I will then move on from that very sort of high summary view of literature and move on to PUI criteria. Next slide, please. So really not a lot to tell you, no real changes in this at all. So just to remind you that in order to decide if someone needs to potentially be evaluated for COVID-19, you have to look at several factors, including epidemiologic risk, and the clinical features associated with that epidemiologic risk change based on the sensitivity that you would like this test to have. So in other words, individuals who are healthcare workers who've had close contact with a laboratory-confirmed case of this virus within 14 days of symptom onset, if they present with fever or signs of lower respiratory illness, they are someone who you should consider testing for this novel coronavirus. On the other hand, if they are coming from Hubei province within 14 days of symptoms or have a history of travel from mainland China within 14 days of symptom onset, they need to have fever and signs and symptoms of a lower respiratory illness. So in other words, we are being sort of a little bit less permissive in those individuals. So they need to have a couple of things happening at once rather than a fever or lower respiratory illness. Again, given that the risk is a bit higher with a known exposure, it makes sense why we would look for a fever would be enough to test, or a cough or shortness of breath would be enough to test. So again, you can see these on the website, the CDC's website. The guidelines or the guidance is still interim, but really no changes to report at this time. Next slide, please. And then in general, we want to just go over the very clear strategy of what to do. The first step in this is to identify persons who are potentially infected with COVID-19. So it's important to have both systems that are both general and specific to identify these folks. So it's good to have posters or signs in multiple languages at entry points directing persons to immediately notify staff if they have recent travel and fever, cough, or shortness of breath. The next step is isolating. So before you even think, you should isolate. So if any of these are positive, if you have someone who has symptoms or has recent travel, it's important to apply a face mask and place them in airborne infection isolation or a single room with a closed door. Also use appropriate PPE when evaluating patients as you decide whether they need testing for COVID-19. So you don't want to decide they need COVID-19 testing after they've not been isolated. You want to take this step first. And then finally, after you've identified them, after you've isolated them, the next thing to do is to give us a call. And again, the state will have a different mechanism for how to reach them. You'll reach their local health departments, but for New York City, we are your local health department, and we'll make sure that you have a clear way to understand how to give us a call so we can help you decide what next steps are for this individual. Next slide, please. And these are the next steps. So if you are identifying someone who may need testing in New York City, on the screen you'll see our provider access line. It's open 24 hours a day, 7 days a week, and the state has provided a very easy link. If you are in another jurisdiction outside New York City, click that link, find your local health department, and take it from there. You'll have a number or another way to contact them, and they will direct you at next steps. Thank you. I'll hand it back to my state colleagues.
Okay, thank you, Dimitri. Next, Dr. Mary Foote from the New York City Department of Health and Mental Hygiene will talk about personal protective equipment.
Hi, thanks, Dr. Blog. So we started talking about this a little bit last week, but the bottom line is personal protective equipment, especially masks and N95s, we anticipate shortages will continue. Part of the main issue is that actually a majority of the masks and N95s are produced in China, so it's not just an increase in demand, there's also a decrease in production that is causing some issues with procurement and delays in getting orders filled. So recently, my wonderful colleagues at the state released a helpful health alert with a letter giving instructions on how to manage supply chains, start thinking about requesting and procurement of equipment if you are having trouble getting it from your regular suppliers. If you did not receive that already, you can go in through the Health Commerce account and look at the letters that have been sent out. So it should be among the materials on Health Commerce from the state. And in addition, wanted to talk about just some general tips to think about while, unfortunately, mask conservation strategies and N95 conservation strategies are not going to be the ultimate solution. It may help mitigate the impact of supply shortages. So taking kind of a safety approach to this, one thing you can think about is engineering controls that you can implement in your facilities to decrease the need for face-to-face interactions that would require personal protective equipment. Of course, the use of airborne infection isolation rooms is very important with this pathogen. And as Dr. Daskalakis was saying, don't wait, isolate. So, as soon as you have a suspect patient, get them in an isolation room as soon as possible. Also consider the use of physical barriers such as glass or plastic windows in places like your registration, triage desks, with your administrative staff, security, et cetera, just again to eliminate the need for those, eliminate the kind of face-to-face exposures that could be happening in the facility, especially before screening takes place. And similar to as we did in Ebola, not that we're comparing this to Ebola, but rooms that were dedicated for isolating these patients also were encouraged to have audiovisual equipment. So there could be either video communication or phone communication with the patients outside of the rooms, which would eliminate the need for healthcare providers to enter just to have conversations or to have non-physical interactions. So I would highly encourage you to start looking at those options and start looking at equipment that you can install both in the emergency departments, in clinics, and also up on your floors in the isolation areas where you're planning on putting these patients to start getting the infrastructure in place to have these sort of more remote communication strategies in place. and thinking about some administrative controls that you can start thinking about. Oh, and one thing I did want to note with the audio-visual communication strategies is also, of course, translation is going to be a big priority to make sure you can have culturally appropriate interactions and linguistically appropriate interactions, so make sure that your language services are in place as well. So next step is the administrative controls. Mass security is already an issue with patients basically seeing any masks on the floors or in your facilities and walking away with large supplies. But in addition, I hate to say it, we've heard reports of staff also taking supplies out of storage areas. So mass security is going to continue to be a priority. So we recommend to remove all N95 respirators from the units that don't require routine N95 protection and work with your infection control staff to kind of prioritize which units really need to have maintained supplies of N95s on hand. That would probably be including the emergency department, intensive care units, and then be judicious in what other areas have masks on hand. And also, same thing with masks. We would not recommend at this point leaving mask stations supplied where the public can grab them, and if you do have a security guard standing next to them to ensure that people aren't running off with multiple with boxes, and just train your staff. If you decide to take those out of the respiratory stations, make sure your staff are trained to recognize when to offer a mask to a patient with signs of respiratory symptoms. And then again, we just encourage you to really message to your staff that this is an issue, this is a safety issue for them, so really emphasize that it is not okay for them to hoard masks, take masks home, and they're much better and much safer having masks to use at work than taking them home with them. And in addition, if you have any other administrative areas, if you have expired supplies of masks and equipment, we would highly recommend using those for training purposes so you aren't using your unexpired stock unnecessarily. And in terms of healthcare worker safety, just thinking ahead, really start thinking about, especially for hospitals, where areas with space where you can co-locate patients with multiple airborne isolation rooms or use of HEPA filters to create areas where you can have environmental controls in place to care for multiple patients with the potential or confirmed COVID-19. Consider having dedicated care teams that would take care of these patients and come up with protocols that would reduce the need for unnecessary staff to enter the patient rooms, especially, housekeeping, dietary services, other extraneous staff, so to reduce other people entering the room that are not part of the core care teams. And then just general other patient, look at your general safety measures. Consider requiring the flu shot for your staff so you reduce the need for staff for regulatory reasons to have to wear masks that aren't vaccinated. And again, take a close look at your visitor policies and start thinking ahead about how you may do visitor screening and visitor restrictions, and really make sure you're messaging clearly about people not entering the facility that are ill, and be proactive with those messagings. And do the same thing, if you're a outpatient facility, also, get your signage out and start educating people as well. And then again, just make sure you have very clear policies in place and staff are educated on what are the clear indications for face masks and N95s. We've heard a lot of reports of staff using N95s for influenza-like illnesses, even though these are not suspect patients for COVID-19. So again, just make sure your staff are informed and trained about when are the appropriate times to be using this kind of equipment. And Again, you can start thinking about working with your respiratory protection program and infection control staff about what are some alternative equipment that you can have on hand or consider purchasing that would replace disposable respirators, things like elastomeric respirators that are reusable, or even PAPRs, especially if you're thinking about these dedicated care team models. So just things to start thinking about. And so we are, just for additional information, again, to look at procuring and requesting equipment, I encourage you to take a look at the guidance that was put out by New York State on health commerce. We at the DOHMH are working on a tip sheet for some of these conservation strategies that should be available on our website soon. And I know our colleagues at New York State are going to be coming out with healthcare worker alert with some additional guidance and helpful links to CDC and NIOSH guidance documents about some of these conservation strategies and other useful guidance documents for this. So again, just things we, for forward planning, want you to be thinking about, and I can turn it over to my colleagues at New York State. Thank you.
Thank you so much. Next, Dr. Emily Lutterloh will talk about healthcare facility infection control. Okay, thank you. I just have a little bit of additional information for you here. The first slide up that you see now provides a link to some new infection control FAQs that CDC has put out. This is in addition to the interim infection control guidance that's been out for some time now. So it will definitely be worth your while to take a look at that. The information in those FAQs includes some information about PPE that was not in the original infection control guidance, such as what to do with transporters within your facility, and what's the risk category if a healthcare worker is not wearing a gown, some things like that. There's also some additional information about some clinical information about if a person has symptoms but doesn't meet PUI criteria, and some reinforcement of the need for AIIR rooms. And then there's one in particular, of particular interest, about asymptomatic people who are undergoing monitoring and present from medical care for reasons unrelated to COVID-19. And that is a tricky issue that we've put a lot of thought into here, and hope to come out with some information for you there. But in the meantime, please take a look at these FAQs. The last bit in there is about environmental services and some cleaning and disinfection, and I have a little bit of information on that. And Deb, could you go to the next slide, please? So with regard to healthcare facility room cleaning routine, as I think was mentioned before, one of the key points with care for COVID-19 patients is to reduce the number of staff that need to go in the room. So for routine cleaning, if you can avoid having EVS staff go in the room at all, and perhaps delegate some of the cleaning to nursing staff, that's one thing that is mentioned. If EVS staff do need to go in the room, they need to wear full PPE, just as other healthcare providers do. Now, for terminal cleaning, obviously, if your PUI is determined not to have COVID-19, then this is not an issue at all. But if you are caring for a patient with COVID-19, then there are several recommendations for terminal cleaning of the room by the EVS, environmental services staff. And the first is to delay entry into the room. This is to allow any droplets in the air to come out of the air. Now, the delay time is a little bit ambiguous. If I know many of you were involved in planning or even caring for patients with measles, and you're probably familiar with this time from caring for TB patients, for example, in AIIR rooms. But it's frequently mentioned as 2 hours. I know some people are using 4 hours just to give an extra layer of security here. There are also tables on CDC's webpage that
provide a number of minutes based on the air exchanges per hour in the room. So you can take a look at that. But the bottom line is EVS staff should delay entry into the room for some number of hours after the patient leaves. And then they should wear a gown or gloves to clean the room, and if splashes are anticipated, a face mask and eye protection. Again, they would not need an N95 because this is a terminal cleaning when the patient's no longer in the room and there's been some time delay after they've left. Now, there are no changes in recommendation for the product that is used. There's no, unlike, for example, Candida auris, there's nothing special with regard to the cleaning and disinfection products used. They should have either an emerging viral pathogen claim, and this is something you're not going to see on the label. This is something that would be transmitted from the company that produces the product to you. Or alternatively, if you don't have such a product, check the label for the products that you use and just make sure that it has an indication for human coronavirus on the label. Now, the last thing I want to go over here is COVID-19 patients in the OR. Obviously, at this stage of the game, we don't have any COVID-19 patients in New York State, but I know many of you are working hard on putting together your plans for the future, so we have gotten several questions about this, and I'm presuming it's because you're planning, and so I did want to address it. So first of all, there could be elective surgeries, which I think we would recommend be delayed whenever possible, and then there are urgent procedures that, we could kind of define as those that need to be done during the potentially infectious period, but are not emergent, and then there are emergent ones. For the urgent ones, there's some time to plan and perhaps call us if you need to. For emergent procedures, what we're saying here is partially based on CDC's recommendations for TB patients who need to go to the OR. And what they generally say is, of course, use the recommended PPE to include N95s or the equivalent, whatever's appropriate for the OR, and eye protection. They also say that the patient should be extubated either in the OR or an AIIR, and obviously not go to the open recovery area. Your anesthesiologist might have some tricks up their sleeves, such as breathing circuit filters with a 0.1 or 0.2 micron pores. And we also get a lot of questions about portable HEPA filters. So for the OR, this is something that you can consider, but it's not something that you can just decide on at the moment and, plug in and set up and move ahead. This is something that needs to be discussed ahead of time with your facility engineers so they can appropriately deal with the exhaust and those types of issues. We also sometimes get questions about changing the airflow or the air in the OR from positive pressure to neutral or negative, and that's not generally recommended. Most facilities really don't even have the capability to do it, but that's not one of the things that are generally recommended, especially for this particular virus. And I think that's everything I have.
Okay, thank you, Emily. Our last presentation will be on lab testing, and Dr. Jennifer Rakeman from the New York City Public Health Lab will speak, and Jill Taylor from the director of the Wadsworth Center at the State Department of Health is available for questions later. So go ahead, Jen.
Hi, good afternoon, everyone. Can you hear me okay?
Yes.
Okay, great. So we just want to touch on a few things about clinical testing for COVID-19 infection. So first of all, the CDC has developed a clinical diagnostic test that can detect viral nucleic acid. Currently, that test is only available at CDC. CDC obtained an FDA emergency use authorization for the test and is looking to roll test kits out to public health laboratories around the country, including New York City and New York State. They are working through some technical issues with that kit and do not yet have a date for which the kit will be rolled out, but we expect it will be soon in the coming weeks. That being said, we also wanted to touch a little bit on laboratory-developed tests and what the emergency use authorization means for LDTs. So when there is an EUA for a test during a public health emergency, that kind of steps up what FDA wants to look at. And so laboratory-developed tests, so tests that a clinical lab might develop and validate based on CLEP regulations and deploy in the lab, actually need to get FDA approval because of the public health emergency. And this is just a way for the FDA to understand what's going on and to ensure that tests that are sort of a higher risk test because they are detecting something new and emerging are tests that are reliable and are good for use for clinical testing. So right now, clinical laboratories are not able to deploy a laboratory-developed test unless it goes through the FDA first. So with that, if there are any questions, we are happy to take those. Unless, Jill, you have anything you would like to add?
No, nothing to add. You did that well. Thank you, Jen.
Okay. Operator, I think we can start to take questions.
The one in particular that popped up, maybe we can wind up. Maybe, yeah. Oh, the operator wants to give instructions. They can do that. Sorry.
Oh, go ahead. You want to give instructions? Operator?
All right. And as a reminder, to ask a question, you will need to press star, then the number 1 on your cell phone. And to withdraw your question, you can press the pound or the hash key. Again, to ask the question, press star and the number 1 on your telephone. Please stand by while we compile the Q&A roster.
Okay,
so
Brian,
sorry about that. So one question that popped up a couple of different times here during the chat so far has been, and Dimitri, I think you mentioned it, is the drugs that were being that had been talked about as being used for treating coronavirus, and questions about whether or not they should be used or availability, that type of thing.
Hi there. So there are a lot of drugs that people have been discussing as possible treatments for coronavirus. So included in that is this novel agent that I presented that just showed some activity against MERS. There's also been some literature about the use of combination or some conversation about combination therapies, some of which include HIV medicines as well as anti-influenza medicines. So the clear message on this call is that everything is investigational, and there are studies that do exist potentially to allow access to novel antivirals. But from the perspective of the providers taking care of a patient, if you think you have someone who has novel coronavirus, please don't try to treat them with some combination therapy. It's important to let the Department of Health know, and then we will sort of continue the process of getting them evaluated and then give further guidance as time allows. So I would say that keep an eye on the literature for your own academic interest, but right now there's no antiviral indicated for treating novel coronavirus.
Okay, thank you. Operator, are there questions?
Yes, the first question comes from the line of Gary Monk. Your line is now open.
Thank you. 2 questions. Has it been determined how long an individual will continue to shed the virus after returning to asymptomatology? And the second is there biphasic where there's an enteric component, as we're seeing with SARS, with diarrhea and spread secondarily?
So I think that, hi, this is Dimitri again. So I think the question is about shedding a virus after symptoms have ended. So I think the jury's out. We're learning more about this as we go along and see more cases, and there's some shedding evaluations being done of cases. I think that at least at the Department of Health, we're taking the perspective that we're going to pick a period of time, most likely 10 days after symptoms have resolved, when we would call someone all clear from novel coronavirus in terms of their isolation. I think there is more sort of study happening, but I think that it's a pretty conservative estimate. So more to come on that. Then the second question is whether there is GI-related shedding of virus. So I think that there are some data around the presence of coronavirus in enteric secretion, specifically also in stool, and there has been some conversation about that as a potential mechanism for transmission. But I will go back to say that the most likely and most common mechanism of transmission that we know right now is the respiratory one, which is why sort of our standard precautions of wash your hands, and which also covers, I think, the enteric transmission perspective as well. Wash your hands or use hand sanitizer, and sneeze or cough into your sleeve or your elbow to prevent droplet generation is still the best guidance. So again, learning more about this virus every day. Most likely, most frequent form of transmission here that's driving this outbreak is respiratory.
Thank you so much. Thank you.
Next question.
And your next question comes from the line of Callie Gerber. Your line is now open.
Hi, I'm a school nurse, so my question pertains to school-age children and quarantining. There was an issue in France of a parent who was unaware that they had contracted coronavirus, COVID, while on a business trip, came home, unknowingly spread it to their children, who then spread it to 2 schools, and they had to shut down and quarantine both schools. My question is, when people are being quarantined as suspected, are they being quarantined away from their school-age children, or are their school-age children being quarantined as well in the same household to avoid that issue?
Well, this call is not about school or community quarantine. I'll just say that the ideal is for them to be separated from their family members. But you can email us if you'd like to discuss that further.
Okay, thank you.
The next question. Next question, please.
And your next question comes from the line of Holly Fisher. Your line is now open.
Hi, I just have a question about if a patient comes in and is being self-sequestered out in the community for travel and they're asymptomatic, is there still a need to do the terminal cleaning and allow the air exchange that need to be done, or is the patient considered not communicable?
Yeah, we think that probably it does not need to happen. That person's asymptomatic and cleared.
Okay, thank you.
Next question.
Your next question comes from the line of Jonathan Chang. Your line is now open.
Hi, as a practicing physician, do we need to wear what kind of mask when seeing patients? N95? When should we wear the N95, or when should we wear the regular surgical mask?
So right now, COVID-19 is not spreading in the community in the U.S., so unless you have a patient with appropriate clinical and epidemiologic risk factors and who is symptomatic, then you would use your standard, your standard procedures for when mask wear is appropriate. If you are seeing a patient that you think warrants, a call to public health who may have COVID-19, then we would recommend, if you're in a setting where it's available, the full and appropriate PPE for COVID-19, which is an N95 gown, gloves, and eye protection. We understand that many outpatient settings where these patients might initially present do not have that PPE or do not have fit tested staff. And in those situations, when it becomes clear that this patient is of concern for possible COVID-19, they should have a face mask offered to them and worn if they can tolerate it, and be placed in a private room with the door closed while you call public health. And Dimitri or anyone else at New York City, anything to add to that?
Couldn't have said it better myself.
Ditto. Nothing to add.
Great, thank you. Next question, please.
And your next question comes from the line of Joy Tabuda. Your line is now open.
Yes, hi. This may or may not be a valid question for this group, but how does the Department of Health interact with the transit people or the airlines that are coming in, people who are coming in or have come in from China? Like, is there a protocol for that, for ships and places where people could come in?
There is definitely a process for alerting us that travelers are coming in by plane and often by ship as well, and actually at border crossings too. So again, this is supposed to be focusing on healthcare, so I'm not going to get into too much detail on that question, but thank you.
Okay. Thank you.
And another question, please state your first and last name. Your line is now open.
Yeah, no.
Please press star 1. Please state your first and last name, and your line is open.
We have questions from the chat. What is it about?
There have been a number of questions about how long things last on surfaces, whether or not things like UV can sanitize, that type of thing. So, a few questions about particularly how long, if there is a positive. Again, there haven't been any in New York yet, but if there is, how long somebody should be, concerned about fomites and virus on surfaces.
So I believe that is under active investigation, but I don't think we have any definitive answers on those questions yet. It is thought that your standard hospital-grade EPA-registered disinfectants will kill this coronavirus, but as far as the length of time it can live on various types of surfaces, we can't give you a number yet in hours or days.
Any other questions on the line?
And we have another question from Marvin Tenenbaum. Your line is now open.
Are there any preliminary data regarding the sensitivity, specificity, and predictive value of the diagnostic tests being used by the CDC?
This is Jill Taylor. We do not know that positive predictive value, negative predictive value at the moment. Sensitivity and specificity have certainly been done and were submitted to the FDA as part of the EUA.
And this is Jen. Just to add to that, the way the sensitivity was done was by looking at the limit of detection, the analytical limit of detection, because that is with the materials available, that is what the CDC was able to do.
Thank you.
That data is available in the online EUA document that you can pull from the FDA website if you're interested.
Any other questions on the line?
Yes, we have a question from Deborah Sino. Your line is now open.
Hi. So we have a suspected patient who walks through a crowded waiting room. What happens with those patients in the waiting room or the family members?
So CDC has defined something they're calling brief interactions versus prolonged contact. So a brief interaction is just like, saying a few words to someone at a triage desk or walking past someone, and those are not considered to put those other people at risk. There's also a consideration for a 6-foot distance, although out of an abundance of caution, we're all kind of treating this as if it's spread via the airborne route. It's not really known how much of that happens versus the traditional transmission route for coronavirus, which would be droplets, and they typically do not spread beyond about a 6-foot distance. So if a person just walks through a room, I think it would all be fine and they would not be considered exposed. However, if a person sits down in a crowded waiting room next to people, in close proximity for lengthy periods of time, that would be a different story, and that's why it's so important to have signage at the doors telling people if they have risk factors to let the triage staff know right away and get a mask on these people and don't let them sit in a waiting room. New York City, anything to add to that?
Nope, we agree.
Thank you.
Next question.
And your next question comes from the line of Helen Lee. Your line is now open.
Oh, hi. My question is, China said now there's aerosol transmitted. That's one of the, transfer other than your sneezing and everything. So that's why we're concerned, what if you pass by someone in the elevator and the elevator someone had that virus and then, they sneezed before and then this aerosol stay in there for a few hours. So how is the CDC aware of that? How do they, that's why a lot of people wear masks in the Chinese community right now. That's number one question. Number two question is, from what I heard from my colleagues and my friends, they said at JFK or the other airport, they didn't take very seriously on the people coming from China or any other part of, let's say they're from Hong Kong, Taiwan, or the other part of the country. They have, even Japan, they have a lot of cases, and they don't take those passengers' temperature or anything. They don't even ask them. But, I think this is very important for New York. Don't have any cases yet, but at the airport, that point, if they take it very seriously, then we don't have to worry about that much. So that's my question.
So this is Emily. I can very briefly address your first question about aerosols. So, the exact routes of transmission and the frequency with which those happen have yet to be determined. We're certainly considering the possibility of what we would call airborne transmission, which is why we're going through all of this with, AIIRs and N95s and so forth. I'm not familiar with the data out of China yet. That's something that I know that, we are very interested in and looking into, and I know CDC is very interested in that too. So as the literature comes out in, peer-reviewed journals, that's something that we will certainly be very interested in. Now, when you say aerosols, if you're speaking of about aerosol generating procedures, that very definitely is a big concern of ours. That's things like bronchoscopies or sputum induction. I think they're including nebulizers and other situations that may not classically be considered aerosol generating procedures, but do result in a lot of extra coughing or poor control of airway secretions like intubation. And those we definitely are considering very high risk procedures where that should take place in an AIIR if at all possible, and staff should have appropriate PPE, including N95s.
And for the second part of your
another question I have is, so the other lady was saying something, but I was saying some people don't even have symptoms before they show their symptoms. They already have ability to transmit the disease to somebody else. That's why we're concerned about this aerosol.
Okay, and your second part of your question, yes, screening is only done for people coming from mainland China at this point. There are recent travel alerts issued by CDC for Hong Kong and Japan, so that may be coming soon. But I think, go ahead.
Oh, no, finish up that. I'll follow up with you.
No, go ahead. I'm done.
I was just going to comment about, again, the asymptomatic spread, though, again, there may be some data saying that there's virus in secretions of people who are asymptomatic. That's not really the way that this is spreading throughout China and other parts of the world. So really it's the symptomatic folks who are the highest risk because they're also likely are shedding a higher amount of virus. So I think, I think that the sort of creating concern about asymptomatic spread, it's good to sort of have that on our radar, make sure we know what the literature is saying in the future, but really our focus should be on symptomatic individuals.
Okay, well that brings us to the end of the hour, so thank you so much for joining, and thank you to New York City, and we will talk again.
Thank you, New York State.
Okay, bye.
Bye-bye.
Thank you. Thank you.
Ladies and gentlemen, this concludes today's conference call. Thank you for participating. You may now disconnect.